I'm James Watt, and I'd like to spend the next 45 minutes talking to you about transcranial motor evoked potentials, why we do them, how we do them, things to think about as we're evaluating the data, and then some anesthesia and contraindication points that we need to consider. So thank you for having me. Why do we do transcranial motor evoked potentials? The primary reason for spinal surgeries is because the anterior aspect of the spinal cord is perfused potentially by a separate blood supply from the dorsal column. And both of the cortical spinal tracts that we are interested in monitoring, both the anterior cortical spinal tract and the lateral cortical spinal tract, are perfused by the anterior spinal artery, whereas the dorsal column tracts, the somatosensory evoked potential pathways, are perfused by the left and the right posterior spinal arteries. Now, there is some redundancy in blood flow. So if there is compromise in the dorsal aspect of the spinal cord, it is likely that we will also pick that up in the anterior aspect, but it is also possible that the anterior spinal artery will make up for some of that lack of blood flow, and vice versa. But there is a small population of patients where disruption of blood flow to the anterior spinal artery is not going to display any changes in the dorsal column pathways and vice versa. So early on, we did descending neurogenic evoked potential monitoring, assuming that that would allow us to monitor the cortical spinal tract pathways. But we had patients that would wake up and they would have no changes in the DNEPs or in the SSEPs, but they would wake up and they were paralyzed. So clearly there was an issue there. And so we needed to continue investigation of techniques in order to monitor the cortical spinal tracts and ensure that we were actually monitoring them effectively. What that meant was that we needed to get above the first synapse in the dorsal column pathway in order to prevent any antidromic activation of the dorsal column pathway. Now, in most patients, there is a primary artery, a primary segmental vessel that's perfusing a good portion of the thoracic spinal cord. We generally refer to that as the artery of Adamkowitz. Now, as I said, SSEPs only monitor dorsal column function. So we need to get up above that first synapse in the sensory pathway, or the second synapse, as we're outlining here, in order to ensure that activation of only the cortical spinal tract pathway is occurring. So as we know, there are three neurons within the dorsal column pathway. The first order neuron synapsing with the second order neuron in the nucleus within the brainstem. And then we have the second order neuron synapsing with that third order neuron in the VPL of the thalamus. So transcranial motor evoked potential stimulation using either electrical stimulation or magnetic stimulation allows us to activate the cortical spinal tract or the cortical bulbar tract above that synapse in the sensory pathway, and therefore there can be no antidromic activation across that synapse in the sensory system, and therefore any sensory activation that may occur at the cortical level is either blocked in the VPL of the thalamus or in the brainstem itself. So theoretically, then, we will use electrical or magnetic stimulation in the operating room. We use electrical stimulation to activate the cortical spinal tract and or the cortical bulbar tract fibers if we are referring to cranial nerve motor activation. As I said, any antidromic activation in the sensory system is blocked via that chemical synapse in the thalamus and or in the brainstem itself, which leaves us with purely a motor potential traveling down the brainstem down the spinal cord, out the peripheral nerves, and then to the muscles. Now we can record from two locations along that pathway. We can record from the spinal cord itself, which if we do that, that's referred to as a D wave, and it is not impacted by anesthetics. Or we can record compound muscle action potentials from the limbs and also from the torso, which will be impacted by anesthetics, both neuromuscular blocking drugs at the neuromuscular junction, as well as IV and inhalational agents that act at the synapse between the upper and the lower motor neuron in the spinal cord, as well as the intercortical synapses in the cortex itself. So we want to understand the two cortical spinal tract pathways. So let's very quickly review those. The lateral cortical spinal tract begins in the precentral gyrus, and then those neurons, those BET cells, those large pyramidal neurons, funnel together through the corona radiata and generate the cortical spinal tract. They pass down through the internal capsule, down through the medullary pyramids, into the medulla, and then the lateral cortical spinal tract fibers, approximately 85 to 90% of those fibers, cross over and make up the contralateral lateral cortical spinal tract within the spinal cord. Those are the neurons that are going to synapse on lower motor neurons that go out to the muscles in the periphery. We then have the anterior cortical spinal tract, which has a similar path, except in the medulla, those fibers do not decussate. They continue down the spinal cord on the same side of the spinal cord as they originated in the cortex. But then at the level that they are synapsing with the lower motor neuron, they cross over, synapse with that alpha motor neuron, exit the spinal cord through the ventral nerve roots, just like the lateral cortical spinal tract fibers do, and then go to their respective muscles. Now, anterior cortical spinal tract we think of as synapsing on muscles of the torso, whereas lateral cortical spinal tract synapses on muscles that go to the periphery. So in most instances, what we are monitoring are the lateral cortical spinal tract fibers and not the anterior cortical spinal tract fibers, unless we are placing electrodes in the abdominal rectus muscles, the intercostals, or other muscles of the torso. I do want to point out, however, there is a small percentage of lateral cortical spinal tract fibers that do not cross over, and they decussate or they synapse on lower motor neurons on the same side as they originated. But that's a very small percentage. Now, if we go back to some of the work that Dr. Amassian did back in his article that he published in '87, we know that those primary BET cells, those giant BET cells, which make up about 2% of the cortical spinal tract pathway, are acted on either in an excitatory or an inhibitory fashion by other intercortical neurons, as well as thalamic connections that then cause either excitation or inhibition of that giant BET cell. So we have that initial direct activation, which we refer to as a D wave, but then we have additional I wave or indirect activations of that same BET cell. And in an awake patient, that's a good thing because that initial volley followed by those indirect subsequent volleys summate through temporal summation in the spinal cord along that lower motor neuron, and then cause that lower motor neuron to reach threshold of activation, and then that nerve action potential goes out and at the neuromuscular junction causes contraction of that peripheral nerve or that peripheral muscle. So in an anesthetized patient, however, we lose those I waves, so we have to generate pseudo I waves or subsequent D waves to cause that summation to occur within the spinal cord. So again, the D wave, direct activation of the cortical spinal tract pyramidal neuron. We can record these from the spinal cord. They travel at about 40 to 50 meters per second, and an electrode placed in the epidural space along the spinal cord will pick up these D waves. A couple interesting pieces to note. D waves amplitude increase as you increase stimulation up to a suprathreshold stimulation intensity, and generally we're going to use the same threshold of stimulation or voltage that we would use to produce compound muscle action potentials that we record from the peripheral muscles. Latency will decrease with increasing stimulation. If you think about this, it's because we are penetrating deeper in those cortical structures and activating the cortical spinal tracts at a deeper level, and therefore cutting off several centimeters, or that can convert to a couple of milliseconds worth of neuronal tissue. Now, in an awake patient, again, following that initial D wave that is generated, there are subsequent I waves that are generated, but they are extremely susceptible to anesthetics, and so are only present in very lightly anesthetized or awake patients. However, it is required that we have this temporal summation in order to overcome threshold of activation on that lower motor neuron. So to give you a visual representation, here's what's normally happening in an awake individual. We have that initial direct activation of that upper motor neuron, but then that intercortical reactivation, those I waves, that allow us to reach threshold of activation on that lower motor neuron that then generates a nerve action potential and causes contraction of that peripheral or dorsal muscle. So here you can see that first initial volley, second, and in this case that third volley is allowing that lower motor neuron to reach threshold of activation and generate that compound muscle action potential. In an anesthetized patient, however, because of the blocking of the intercortical neuronal communication, as well as blocking that occurs between the upper and the lower motor neuron, that single activation, that D wave, never allows for the generation of I waves, and therefore we never reach threshold of activation. So what is required then is we use multiple pulse stimulation, and each of those subsequent pulses, in this case 3, each generates a D wave followed in rapid succession, one after the other, allowing that lower motor neuron then to reach threshold of activation, and then we can generate a compound muscle action potential, assuming that no neuromuscular blocking drugs are present to block acetylcholine at the neuromuscular junction. Now, we can then, as I said, record D waves or compound muscle action potentials, and there is a slight variation both in the recording but also in the stimulation parameters that are used. So D waves can be generated and recorded using a single pulse stimulation paradigm, whereas compound muscle action potential recordings require a multi-pulse stimulation paradigm in order to overcome threshold of activation at that lower motor neuron. D waves we can monitor in a continuous fashion about once every second if we have the need to do that, as there is generally no patient movement experienced. And as a matter of fact, if you are only doing D wave recordings, neuromuscular blocking medications could actually be administered to eliminate any patient movement. Whereas CMAP recordings require an intermittent monitoring technique, because we need to do it in conjunction with communication with the surgeon, because there is potentially significant patient movement that can occur. Now, patient movement can also introduce a safety risk to the patient, because if their head is in pins, or the surgeon is working on a vascular or neuronal structure, it's very easy with that patient movement to cause injury. So we want to make sure that we control for that and eliminate the possibility of injury as much as possible. One of the things that we will do is to place, or have the anesthesiologist place, soft bite blocks to eliminate the risk of tongue and lip lacerations as the patient bites down. Now, D waves are more invasive because the surgeon needs to place an epidural recording electrode in the epidural space, whereas compound muscle action potentials can simply be recorded by placing needle electrodes in the various muscles. Stimulation, then, we will use the same voltage or current parameters for both compound muscle action potential recordings or D-wave recordings. However, with D-waves, it is a single pulse that we are going to use, whereas for compound muscle action potentials, to overcome threshold of activation in that lower motor neuron, we will use anywhere from 2 to 9 pulses delivered in a rapid train of stimuli in order to evoke that response. Now, in systems with constant current stimulation, we will use a wider pulse width of 500 microseconds or 0.5 milliseconds, whereas in constant voltage stimulation paradigms, we will use 50 or 75 microsecond pulses, each delivered with about 2 to 4 milliseconds between onset of each pulse. So compound muscle action potential recordings, again, a single or a multi-pulse stimulation paradigm, whereas D-wave recordings, a single pulse stimulation paradigm. Now, parameters that we can adjust in order to optimize our stimulation and D-wave or compound muscle action potential recordings are ensuring that our electrode location of our stimulation leads is optimal. We can also vary intensity, number of pulses, interstimulus interval, and then pulse width to try to optimize stimulation. Now, it is recommended that we use leads placed slightly anterior to C3, C1, C2, C4 to activate the motor cortex. And in younger patients, the motor cortex may be even slightly more anterior, so we would want to use leads placed even slightly anterior of M3 and M4. Now, we can select for lower extremity activation and potentially less patient movement by using M1, M2 as our anode and cathode, versus if we are trying to activate upper extremities, M3, M4 as our anode and cathode. So generally, I'll recommend placing leads at M3 and M4. And then if we are trying to select for lower extremity activation or minimize patient movement, we will move more medially to M1, M2 as the anode. It is also possible to use the linked quadrupolar technique that Dr. Lima puts forward, where we use electrodes placed at M1 and M2 or C1 and C3 as the anode linked together, and then vice versa, M2 and M4 or C2 and C4 as the anode if we are trying to activate left limb muscles. The benefit is that we can use a lower voltage and still see the same repeatability and amplitude of compound muscle action potentials as we would if we use a single anode versus the dual anode or linked anode cathode technique that Dr. Lima talks about. Increasing voltage will often result in greater recruitment of motor units. Therefore, we will have larger and more complex compound muscle action potentials. So here's an example of that. The voltage did not change. Interstimulus interval did not change. The only thing that changed here is the number of pulses. So here you can see that we delivered 3 pulses and began to generate a compound muscle action potential with a high degree of repeatability. And then as we added pulses, we recruited more motor units, and therefore the complexity and the amplitude of the compound muscle action potential became greater and greater. In this case, 7 pulses seems to be the largest amplitude and also the most complex compound muscle action potential. Notice that the latency, the onset latency of these compound muscle action potentials does not change with the number of pulses. We can also vary the interstimulus interval. Interstimulus interval, the time between each pulse, may allow us to select for upper versus lower extremity activation. Here you can see that this is recorded from the foot, and as we increase the interstimulus interval, it appears that the complexity and the amplitude of the compound muscle action potential became greater. So in this case, we would use 3.5 interstimulus interval in order to evoke these responses. We can also, if we are using a constant voltage stimulator, vary the pulse width from 50 to 75 microseconds. If we're using constant current, we are generally going to be limited to 500 microsecond pulses in order to achieve the appropriate charge in order to activate the cortical spinal tract pathway and record a compound muscle action potential. Now, I do want to point out that anodal activation seems to be the most favorable for producing compound muscle action potentials at lower thresholds. The reason for this is that when we are activating neurons along their axis versus perpendicular to their axis, the generation of isopotential fields underneath the anode are more favorable for activation versus the isopotential fields that are generated under the cathode. What we believe happens is that there is essentially under the anode, there is a hyperpolarization above the cell body of the pyramidal neuron, causing a flow of ions or generation of those isopotential fields in the patient's tissues that then cause a virtual cathode to be created just below the cell body, and therefore activating that pyramidal neuron just below the cell body. Whereas if we stimulate using the cathode, there is a deposition of negative charge above the cell body at the apical dendrite, but then because of the flow of those ions within the tissues and generation of those isopotential fields below the cell body, there is actually a virtual anode that is developed, and therefore those neurons essentially experience anodal blocking. So opposite to somatosensory evoked potentials, where we are activating underneath the cathode most favorably, in this instance for transcranial stimulation as well as cortical stimulation when we were doing cortical mapping, activation is more favorable under the anode. Now, if you turn the voltage up high enough, you will generate compound muscle action potentials under the cathode as well, but for safety purposes and for preventing crossover activation, we generally keep our voltage as low as possible and then place our electrodes such that the anode is over the cortical tissues that we are attempting to activate. So D waves will be recorded using an epidural spinal electrode placed in the surgical site. In the epidural space along the spinal cord, there is some risk here, so surgeons oftentimes are reluctant to place these leads. But when there are situations like an intramedullary spinal cord tumor or a spinal AVM, where a high degree of understanding on a second-by-second basis of what's happening to the spinal cord and making sure that functional integrity is maintained as the surgeon is working in the spinal cord, D waves can be beneficial. Now, I want to point out that as we move further down the spinal cord, the latency of the D waves will get longer and the amplitude of the D waves will drop. That's because there is a little bit longer time before that nerve action potential hits that epidural electrode, which is why the latency increases. But then the amplitude drops because as we move down the spinal cord, there are fewer and fewer cortical spinal tract fibers that are contributing to that D wave response. Now, generally, if we're recording D waves, we record D waves above and below the surgical site. Obviously, the D waves below the surgical site are what we are evaluating for change. The D waves above the surgical site are used as a control. These electrodes we can also use to record spinal SSEPs, and in that instance, the electrode below the surgical site then would be the control. The electrode above the surgical site would then be what we are using for evaluation of change in function. Now, we can also record compound muscle action potentials, much less invasiveness here. And also we are monitoring the entirety of the pathway from the cortical activation or just below the cortex activation of those cortical spinal tract fibers all the way down the spinal cord, all the way out the peripheral nerve to the muscle. These are multiphasic muscle responses that are generated. Again, a train stimulation technique is required, and we generally don't monitor these for changes as far as the morphology from compound muscle action potential to compound muscle action potential, because there is the potential that every time we stimulate, there is a different pool of motor units that are activated, and therefore the compound muscle action potentials are going to vary from trace to trace. These are extremely sensitive to anesthetic changes, and so we need to work closely with our anesthesia provider in order to make sure that an appropriate level of anesthetic is maintained so that we do not lose these due to an anesthetic issue during the course of the procedure. Also, to make sure that the voltages are lower and therefore an increased level of safety for the patients. Of note, and I'll talk about this shortly, but TIVA for patients with any level of myelopathy is generally recommended for these procedures. The technique that I usually start with 4 pulses. I usually start with an interstimulus interval of 3.5 milliseconds, and I use constant voltage, so I usually start with the lowest pulse width of 50 microseconds. I increase my voltage until I get to 300 volts, or I get nice compound muscle action potentials from the muscles that I am recording from. If by the time I get to 300 volts I don't have nice, repeatable, reasonable amplitude compound muscle action potentials at 300 volts, then I begin to add pulses up to 7 pulses. At that point, I'll increase the pulse width to 75 microseconds. And then at that point, if I still am struggling to get good data, I will increase up to 9 pulses. And then, only then, will I go up to 500 volts. I also will use a multi-train facilitation technique, which will sometimes improve my ability to record compound muscle action potentials. And oftentimes now I actually will begin with Dr. Lima's linked quadrupolar technique so that even if I am able to evoke responses, say at 300 volts, I can use a lower, safer voltage for my patient. The less amount of voltage that I have to deliver, the less amount of charge that I have to deliver to that patient, the safer that it is for that patient. And I definitely want to maintain patient safety. So then we can use a multi-pulse train facilitation technique where we use one of the techniques is using a preconditioning train where we stimulate the sole of the foot at 2 hertz for a couple of seconds, and then we do the transcranial electrical stimulation. Now, based upon Dr. Sloan's recommendations, anesthetic should be maintained such that no more than a half a Mac of inhalational agent is administered, and then using propofol guided by EEG. So in other words, keeping that patient out of burst suppression, keeping faster frequencies like alpha activity if possible, and then NMBs, neuromuscular blocking drugs, need to be avoided when recording compound muscle action potentials. For patients with significant neurologic deficits or myelopathy, total intravenous anesthesia is recommended. So using propofol, again guided by EEG, and then supplementing with opioids and avoiding neuromuscular blocking agents. Dexmedetomidine is a medication that could be administered. And the reason for administering dexmedetomidine or Precedex is that it has a MAC sparing effect where it will allow for the limiting of the amount of other medications like gases or propofol that have to be administered, and therefore potentially will improve one's ability to maintain stable transcranial motor evoked potentials, CMAPs. However, there is also anecdotal information out there indicating that dexmedetomidine, Precedex should be avoided when monitoring children, as it seems to have a detrimental impact on the ability to obtain compound muscle action potentials in those children. Procedures where we might use transcranial motor evoked potentials, any procedure where the spinal cord is at risk for injury, so spinal deformities, instrumented spinal cases, intramedullary spinal cord tumors, aortic aneurysm surgeries where blood flow to the spinal cord may be at risk, and then also posterior fossa tumors. And in that instance, we may actually want to use a technique, which we're not going to cover here, to monitor cranial nerves using transcranial electrical stimulation, and then intracranial aneurysm surgeries, and periorlandic brain surgery, keeping in mind one caveat that we need to use as low voltage as possible because we want to make sure that we are activating those cortical spinal tract fibers as close to the surface of the cortex as possible, because as we increase voltage, the penetration and activation of those cortical spinal tract pathways is deeper, and therefore we may bypass our ability to recognize changes that are happening at the surface of the cortex by activating deeper within the cortical spinal tract pathways, for instance, at the internal capsule. Change criteria that we apply then, Dr. Delitis, if we are monitoring just compound muscle action potentials, his change criteria is all or none. If we have compound muscle action potentials at whatever voltage preserved, we know that that pathway is intact. If we do not have compound muscle action potentials, the assumption is there is a compromise to the cortical spinal tract pathway, and the surgeon needs to intervene on behalf of that patient. Now, if we're doing D-wave and compound muscle action potential monitoring, generally we want to report any changes to the D-wave up 30% or less. The surgeon needs to intervene. Once we approach 50% reduction, that patient is likely to have a permanent motor deficit. And so at the point at which the D-wave reaches 50%, it's too late. So our criteria needs to be more sensitive than that. And so when we hit 30%, the surgeon needs to intervene. Now, in reality, D-waves are generally very stable. So if I see any change to the D-wave at all, I'm going to let the surgeon know that so that they can take corrective action at that point versus waiting to get a 30% reduction in my D-wave amplitude. All right, so this is referred to as the all or nothing technique put forward by Dr. Delitis. Dr. Calancy puts forward a threshold technique in which we turn up our voltage until we begin to see compound muscle action potentials in the various muscles that we're recording from. And so we set a separate threshold for each muscle. And then if those muscles threshold increase by 100 volts or more during the course of the surgery, that is criteria by which we need to notify the surgeon that there is a potential change in progress and they need to intervene. This is a little bit more sensitive method because we're going to also have more situations in which the anesthetic causes us to reach threshold of criteria to notify the surgeon here. And it can be a little bit more time consuming, and the surgeon may not have patience to wait for it because we have potentially separate thresholds for various muscles that we're recording from. And then Dr. Yingling puts forth the complexity technique, where the complexity and the persistence of the CMAP is what we want to analyze. So we should expect a multiphasic persistent compound muscle action potential. If that becomes biphasic and or less persistent, that is a situation in which we want to let the surgeon know that there is a potential change in process, and by the time it's absent, the surgeon needs to have intervened on behalf of that patient. Okay, some safety considerations. Using electrical stimulation, thermal injury, electrochemical injury, excitotoxicity, these are all concerns, low concerns, but yet concerns. Of higher concern, we have the concern with causing seizures in the operating room due to our stimulation, and therefore EEG should not only be utilized to guide the level of propofol administration, but also to understand if there is any after discharge activity being generated from transcranial stimulation. Also, it is possible using our transcranial stimulation to cause potential cardiac issues. And then also, if there are any skull defects, we want to make sure that our stimulation electrodes are not placed over top of those defects where there is a potential direct path to those cortical and subcortical tissues for that current to shunt and potentially cause injury. Also, movement-induced injury is a potential risk here.